you have a scratch reflex that basically is on the thorax, and I'm going to add, it's a rapid scratching movement in the ipsilateral hind leg. Well, in a human, you see people scratching their head, their face, their chest, different areas of the body. And I found that that relates a whole lot to the scratch. Looks like a tremor. So if you find an area that's itchy, that they're scratching all the time, or that's dry, which can become itchy, you take the small tip probe and you go over that area, and it's going to help with the tremors. We've seen this meet out several times. I had a doctor in a seminar, when I called on him, anybody that had a tremor, he said, as if nobody noticed, he had that going on both sides. And I asked him, do you have any itchy areas? He said, no. Do you have any dry areas? He said, yes, from about 4 inches above my elbow to 4 inches below. I said, okay, well, roll your shirt up. And it was really dry and crusty, so I took the small tip probe and I went over it, and as I did, tremors got about 3 times worse. And this was in San Antonio, Texas, by the way. But as I got the points down and extinguished, all the tremors left. And then I went to the other side and it reacted in just the same way, and we got rid of all the tremors in a matter of minutes. And so, you know, those can come in handy, and we're going to talk more about those later as well. Tremors, skull tremor lines. You go to governing vessel 20, about a ½ inch back. The line goes down to about 3/4 of an inch behind the side of the eye. You would either interweave a long needle through there or just tap through it. Ticklish or dry or itchy areas, you can needle that. You can tap it with a small tip prod. Also the biceps, brachioradialis, or the lat at the insertion point, right up under here, really help tremors. Okay, now let's take a look at 9A, your electrovibratory body. This is basically talking about chakras. Now there are 7 spinal chakras, and there's also 21 minor chakras. We're not going to delve into the minor ones, just the major ones here. And here we have the colors: indigo or brow center, and we have the violet or the crown center. We have the blue or the throat center, which goes through to approximately the 2nd cervical vertebra. We have the green or the heart. This goes basically through to about the 1st thoracic ganglia, which would equate basically with governing vessel 14. Here's the solar plexus. This is about the 1st lumbar vertebra, which is orange. We have the coccygeal spinal ganglia, and it's way down here in the sacral area. Okay. Now, the only reason I bring these up is that kind of the theory behind these is that they're the inlet for universal energy into the body, and that's what this is about. So I'm just mentioning it from that standpoint. The minor chakras go into it a little bit more, how they're channeled into the acupuncture meridians, but I just thought I would mention this particular thing. Now we have 9B as in boy, auriculotherapy. And I'm bringing this particular one up because it has the foot right here. It's the only one that I've seen that has this particular spot for it. And I had a patient that was having all sorts of foot problems, and I was using a lot of auriculotherapy at the time, and I wasn't finding anything that would work. And so I took the edge of the prod here and I put it down on that area. And as soon as I did it, the patient felt a flood of circulation into the ankle and foot on the ipsilateral side, and the problems went away. So I thought I would mention that here because this is the only auriculotherapy chart that I found this on. And again, you know, I mentioned that charts aren't all the same, and I've searched all over to find different ones and see how they differ and how they compare with each other. So that's one of the big things that I would say about that particular one. Now here is 9B-1, and this is out of ear acupressure. And I think this is a very good rendition, one of the better ones that I've seen about auriculotherapy. But we're going to see some other ones. This is, I think, a very good visual chart. 9B-1B, here's Guyton's textbook of physiology. It's 5th edition. Excitation, the process of eliciting the action potential mechanical stimulation. Now, in some skin areas, arteriovenosus anastomoses, which are large vascular communications directly between the arteries, venous plexus, the walls of these anastomoses have strong muscular coats innervated by sympathetic vasoconstrictor nerve fibers that secrete norepinephrine. Now, I chose it out of the 5th edition because in the 9th edition, 3 of these dropped out, which I don't think that structure has changed, anatomy has changed in that amount of time, so I don't know why they dropped them out of there. So basically, the arteriovenosus anastomoses are found principally in the volar surface, hands, feet, lips, nose, and ears. And I think that's why you have a lot of hand and foot reflexology and acupuncture, nose acupuncture, and auriculotherapy. Now notice that's the volar surface, which would be the front surface here, which we just talked about. So I think that that particular chart relates to the sympathetic nervous system, according to Guyton. 9B-2, now here is the back of the ear. That was the front of the ear. So we're going to take a look at the back. Here's the ear, gateway to balancing the body. Now some of you may not even have ever seen a chart of the back of the ear. And we've included all the references going back through here. And the thing that should jump out at you is, hey, there's stuff on the front and the back. And basically the back is different. It's a different type of innervation. But here are all the things that, you know, have been found to be helped by it. Now, so let's go to 3, and let's take the innervation of the back part of the pinna. Okay, so here we have Gray's anatomy, and the back part of the pinna, we already looked at the volar part that's sympathetic. Well, the back part, you have the 10th cranial nerve, okay? The auricular branch here. It's also the back part of the auditory meatus. So that's where the innervation is, again, to the back of the ear, here. It's causing that. So you have the front of the ear, which is sympathetic innervation, You have the back of the ear, which is from the 10th cranial nerve. So now we're looking at the science of it and how that could relate. You can stimulate a nerve anywhere along its course and cause a reaction anywhere along that nerve. So this is why you can have reactions in other part of, let's say, the vagus that goes to the vagus organs, or the sympathetic nervous system that goes to the whole sympathetic system. And you have the various branches. So that's the science behind this. 9B, 2B. Now here is something that's on the tip of the ear. One thing about this particular thing on the ear is when something, let's say, hits the ear here, the pinna, then the arm goes up like this. And you want to protect the ear, and at the same time the leg goes down, and on the opposite side everything curls up. So you're trying to get away from it and your body goes away like this. Well, let's say it gets stuck in that position. How do you get them out of it? Well, basically you take and you pinch the top of the pinna of the ear. Just pinch around and you'll find a hot spot there. And as you do, all these areas will let up. So here you would have tension in the, let's say, upper trapezius. On one side, the deltoid over here. And up in here you would have the abductors of the thigh. You have a dorsiflexion of the foot. You have hamstrings that are in contracture. Here the lat would be contracted on this side. It'd be hypotonic on this side. The neck would have tension here. Well, you pinch on that and you just hold it, and all those will resolve. Now let's say that you hit the palm of the hand or the palm of the foot, okay? Well, the reaction is the hand will withdraw. Now here it has a cat that's going down, but in a human, it would go down like this, okay? So you would have this type of reaction, the elbow going down, only would come down here, and the bicep would be in contraction, for example. And you would have a similar reaction here as here. And basically you would go down, it would be just the opposite of the other thing. But here the damage would be to the palm of the hand or the palm of the foot. And you would take the prod to those areas and it would clear these areas up. So, you know, depending on whether the insult was to the palm of the hand, causing this to retract, or the foot, this going up. Now, one thing I want you to notice is when that happens, it can cause all sorts of extremity issues in that extremity, as well as others. So I can have that. Now, I want you to just think about how it occurred. Now, this would be like this, and on the foot, maybe you stepped on something. So you have a withdrawal reflex in either case. But you have all this that happens at the same time, and let's say you get stuck in it. Well, relieving that with prod, with needles, would exactly reverse that. Well, just imagine any other thing. Let's say you caught a ball back like this, and it stung your hand. You would go, ow. So the whole body reacts and twists to get away from it, and you would have to look at the reaction to see what happened. Here, the back muscles would contract. Let's say the infraspinatus here on the back side would go into contracture like this. And the head would go away like this. You would have a twist in the neck. And just basically imagine any reaction to any type of insult. And where the insult occurred, you would prod with the small tip prod and possibly needle anything that you couldn't get gone with the prod quickly. And it will exactly reverse any of these types of reactions that occur after that insult. So you have to use your mind on this in order to get it. And let's not think necessarily in any particular acupuncture point. You're looking for the insults. And remember, acupuncture points can occur anywhere. There are some along distinct meridians, but a lot of them aren't. Okay? 9b4, Nogier was the first to come up with auriculotherapy. It wasn't the Chinese. So he came out with a manual, I think it's like 4,000 pages, 4,500 pages, something like this. He did a lot of research on it before he published anything. So here you have a comparison of Chinese and Nogier points. Now, okay, the Ni Ching, the Yellow Emperor's classic of internal medicine, described how certain meridian systems converge upon the ear. Well, he had several people come into his office, and they were successfully treated by sciatica, for sciatica, by cauterization of one spot on the external ear. And so he started, after seeing a lot of these patients, he started saying, well, it does it for that. I wonder, if there are other points that could relate to other parts of the body. So that's where he started his investigation. And he found a homunculus. In other words, he found areas that kind of look like an organized body that things would relate to here. And Nogier first presented his findings on auriculotherapy in the early 50s to a French acupuncture society. And once this was presented, the Chinese conducted very thorough and systematic investigations of their own. They hadn't come up with this, Nogier did. And they discovered additional points not noted in Nogier's auricular charts. So, following the publication, Nogier revised some of his earlier maps, and he researched further, and as things happen, things change a little bit. Well, here are some comparisons, one with another, and here are the various parts of the ear, like wall of the antitragus, wall of the antihelix, and here are the named areas of the ear, okay? And here are the homunculi, 2A, according to Nogier, Chinese, inverted. And so this is an inverted type. More detailed pictorial description of the auricular somatotrophic pattern. It's more accurate according to the present authors. So it's changed around a little bit since then, okay? So here we have fingers, hand, knee, wrist, etc., heel, toes, ankle. Like I said, that one chart that I found, I extraneously found this one area. That other chart's the only one that I saw that found what I found, so I'm reporting that to you. That's in addition to these. And so here we have this. And this, just for your information, you can use this, as a reference. Chinese, both the somatotropic maps formulated by Nogier and those developed in China were based on experiential findings, not just theories. So they went and they investigated it, okay? These methods are based upon the observation that when there's a dysfunction or discomfort in a certain part of the body, there's an increase in the tenderness to applied palpation and decrease in electrodermal skin resistance of a corresponding ear point. Now, they use acupressure massage, needling, electric stimulation. First time I ever saw this was in auriculotherapy class, and they had electrostim. Actually, the first time I was ever treated with acupuncture, it was electroacupuncture on the ear, and I had turned a bone in my foot. I was a scholarship athlete in track in college, and I was hurting really bad. And the chiropractor that I went to took an electrotherapy, and he zapped at one point, and the pain went away for 6 hours. And I was astounded. So I was sold on acupuncture now. He did needling on me later in different areas, never got anywhere. But that didn't matter because I had experienced this. One of the things that I will tell you that I have found in my own experience that is different in treating the auricular points is when you put a pressure on the point in auriculotherapy, as the area it controls in the body clears up, this point gets more and more sensitive, which is just the opposite of points in the rest of the body. Normally, as they get better, the points that they control get better too. Here, again, I take this small tip prod and I put it and I find that sensitive spot, and as it gets more and more intense, the corresponding area of the body experiences more and more relief. Okay, so I wanted to throw that in with this so that you would have that out of my experience also. Here he has a reflex response of the cardiac pulse, called the auriculocardiac reflex, later named the vascular autonomic signal, or VAS. Okay. And basically, as we go through this, I'm just going to give this to you so that you have the entire document and you can go through it yourself. I've highlighted maybe a couple of areas for you. There's no need for us to go through that other than what I've told you, because basically this is reference. You're probably going to find a few things that they didn't, because as you notice, as the Chinese found stuff Nogier didn't, then Nogier himself found things that he hadn't before. So this is ongoing investigation, and people find things all the time. So you're probably going to find some things that add to these charts as well. And I would like to know about them, whatever it is that you find that's very consistent. If you wouldn't mind, let me know about it. So basically, I photocopied this out of a journal article that compared all these. And here it is, American Journal of Acupuncture, July through September 1983. So that you would have this for your own reference, and you would see the comparisons and the differences, and that this is a work in progress. And there are some references out of it for you. So you have all of that document for yourself. Now we're on 9C, as in cat. Here's the treatment of disease by acupuncture. I would suggest that you buy all these, make your own library. You know, that's how I learn things. I'm stumbling across new things all the time that other people have found, and I'm relating to you things that I found that haven't been found relative to acupuncture. In addition, where I've found things that then stumble across some similar things in the already established literature. So everybody adds to everything. So here we have the treatment of disease by acupuncture, Felix Mann. Okay. Now the very last chapter in this is periosteal acupuncture. It's particularly efficacious in the diseases of the joints. We're going to be going through some things a little bit more than this, but this is my first knowledge of this. And he talked about pecking the periosteum. And so he took needles, and I practiced this for a while, okay? And I found some good results, and then I started wondering, well, do people need to use needles necessarily, okay? And look, I've repeatedly stimulated the skin, muscle, or major nerve trunk over a joint, found it as a rule is not as effective than when the periosteum is stimulated in the correct place. Basically, anywhere where the skin covers a bone or a joint, which is a bone, okay, you scrape over it. You find an area basically where the you've knocked a knuckle against something and it becomes inflamed, and that nerve becomes inflamed, then the joint becomes inflamed, then other things become inflamed that are distant from there, which we're going to be covering a little bit later, okay? But basically this is what you do with that. And we already talked about fractures and how you can deal with fractures. Well, this is where I kind of originally came up with this about how to deal with fractures, although he doesn't mention that in here. I expanded that knowledge. But basically wherever you bump or bruise the periosteum of the bone, scar tissue set up, and you got to break the scar tissue up because it's irritating the nerve, and the periosteum is particularly rich in pain nerves, okay? But you're also going to see that it actually reacts to spreading pain to other similar areas that come out of that area to distant parts of the body. And we talked about a few of those when we talked about fractures. So it depends on how big the bone is, how big the area is, as to how big the ball tip is that you use scraping that bone or that fracture, okay? So here is the entire last part of that chapter for your perusal. And he talks about, you know, some of the ways that he uses it here. For example, large proportion of patients with low backache or sciatica may be helped by needling the sacroiliac joint. And you can needle that, or you can just scrape it with that big ball tip prod, okay? Now he's talking about going into the joint between the sacrum and the ilium. I've used that before, but I find that basically you don't really need to do that. I assume acupuncture is a benefit in these conditions as it alters the tone of the lumbar muscles, okay? And again, you know, we talked about, particularly Felix Mann, he said that any acupuncture point can be used to tonify or sedate. And I really believe that after using this for decades. And as you use this more and more, then you will find that, okay? And he talks about his own particular things that he used it for. And this is for your perusal. Now, Norman Shealy of Wisconsin, a neurosurgeon, heard about that. And he, I think, later on went to Missouri. And he's a very noted research doctor. And he's in Springfield, Missouri now, I believe. He has a lot of things out, and he used dry needling, peck the posterior intervertebral joints. Dr. Shealy was the first to do. He would stick a needle in, and he would put current in it to help get rid of back pain. So he called it percutaneous nerve stimulation. That's the same Dr. Shealy. Here he's talking about prolotherapy with Dr. Hackett, getting similar types of things. He's talking about a 28 gauge 2-inch needle, and that's the type of needle that this is right here, 28 gauge. Now I tend to use a lot thinner needle lately. I used only 28 gauge for a long period of time, and the patient always knew it was going in and usually felt, you know, a lot of pain with it. But I've gone to a lot thinner needles, such as the Sri Lankans use, you know, for a couple of decades now, and find that I get even better results without causing the patient pain. And that would be like this, with this particular brand. And you see the type of needle down here, and There they are for that particular use, and that's what I mostly use now. Not saying I never use the 28 gauge, but basically I want to cause as little pain and discomfort to the patient as possible. Get the job done just as quickly as possible. Now he's talking about a 30 gauge needle. And there you go, okay? So you have a pretty good amount of that chapter there to go by. Now 9C-1. Here's something when you're looking at stimulating, let's say taking care of diaphragmatic and breathing type of problems. Now, we tend to think about the diaphragm as being from the phrenic nerve, which is about from the 3rd to the 5th cervical vertebra. And that's true. But look at this. It's the pain line right here, sympathetic, pain innervation of the viscera, the pain afferents from above the thoracic, below the pelvis, traverse parasympathetic pathways. Okay, so here we have sympathetic here, right here, but look at this. Central part of the diaphragm is the phrenic nerve, but the peripheral part is the intercostal nerves. Wow. Who would have thought that? So basically what you do is to affect that from the bone with the periosteal pecking, for example, is you would peck along, say, now the diaphragm attaches from about the 5th rib all the way down to the 3rd lumbar vertebra, okay? A lot of people don't realize that it goes up that high. So you could scrape, let's say, the spinous process and the ribs from about T5 all the way down to L3, as well as C3 to 5, and maybe along the ribs and the rib cartilage to help the diaphragm to work better. Now, that being said, what goes through the diaphragm? You know, what in particular? Well, basically the nerves that control everything in the abdomen pierces directly through that diaphragm, and especially from those lower 4 ribs, okay? The abdominal aorta goes through it, so taking all the circulation to everywhere below the diaphragm. 3 major veins with circulation coming back through, and the cisterna chyli and the esophagus goes through there, okay? As well as that, behind the diaphragm, you have the psoas and the psoas minor that attach up maybe as high as the 10th thoracic area. So a lot of people who have trouble in the legs and the function and the sacroiliac, which those 2 muscles attach to, down at the lesser trochanter in the upper thigh, you can affect those by releasing the diaphragm, or go to the lesser trochanter by releasing the psoas, for example, affect the diaphragm. The cisterna chyli affects all the circulation in returning from the abdomen and the lower extremities. So, for example, in this case, if you had fluid in both extremities, which is called dropsy, you have swollen ankles, feet, swollen legs on both sides. You have ascites, which is retention of fluid in the abdomen. Well, you release the diaphragm by releasing these points along the ribs along the spinous tips. Now the diaphragm's working. Now all that fluid goes out of the abdomen and out of the lower extremities. Not only that, because that happens, that person automatically loses weight because they're losing fluid weight. And this is without any change in exercise, without any change in diet. I've seen people lose as much as 50 pounds of water weight simply by restoring the action of the diaphragm to what it should be, taking the tension out of it. And you know, it's kind of like a miracle when you do this for people. So you can scrape again along the ribs, scrape the spinous tips, and free up the working of the diaphragm, and all these other miraculous things start to happen. And remember, the nerve that goes to control all those abdominal organs, that's freed up too, and those organs just start to function better when you free the diaphragm up, because you took the pressure off the nerve. Okay? 9D. Okay. Use of laser on acupuncture points for smoking cessation. I'm not saying laser's good or bad. You know, it can have its good points. But basically, we'll talk about cessation, and we'll talk about a couple of specific ones. 9D1. How to stop smoking, a new acupuncture point discovered. And this is in July, September '81, American Journal of Acupuncture. And basically, here's the anatomical snuff box. Here's a bump. Right behind it is a dip right here. That's the point that he's talking about. Okay? There's also a point, if you find the nasal bone, you go to the middle part right there. There is a stop smoking, let's say, addiction point. I use all of these for addiction. 9D2, International Academy of Clinical Acupuncture. Here is the Amaro addiction point. So you go to the middle of the earlobe, you go over roughly about a ½ inch and up a ½ inch. So when I work on somebody for addiction, I use all three of those points bilaterally. Now, a word of caution, and I used to do a lot of this, and what I found basically was that people would come in and they would want to stop smoking. They would want to stop alcohol. They would want to stop drug addiction. Okay, that's great. And we had several people, just one treatment, and their cravings stopped. Okay. And the interesting part of it, however, is I had several people, particularly with smoking, they went from like 1 pack to 2 packs to 3 packs to 4 packs. And I'm going, why is it getting worse? Because when you do this, it makes the taste really bad. They say it tastes really metallic. It tastes like oil and dirt, like crankcase oil and dirt. And I said, you know, it tastes bad. Why are you smoking more? And they said, well, I remembered how good it tasted and I want to get that taste back. Then it occurred to me, are you here because you want to quit, or because your spouse, your siblings, your children, or somebody else wants you to quit? And they always said, oh, they don't want me to quit. I enjoy smoking. And from that I learned, and I've talked with several other people that do acupuncture that way too, and they found the same thing that I did. So from that point forward, before they ever come in for stop smoking, stop drug abuse, stop alcohol, whatever, getting rid of the addictions, I always ask them, do you want to stop or does somebody else want you to stop? Because if somebody else wants them to stop, it ain't going to work, okay? So they have to have that desire because they just enjoy it so much. But you have people that don't enjoy it and they genuinely want to stop. Those are the people it's going to work on. And it's not that you don't make them crave it less, because you do. It's not that you don't make the taste really foul, because you do. It's not that at all, because you can cut the cravings. And normally what I see, let's say somebody's on a 40 pack a day, okay, or 40 cigarettes a day. And you have those that just stop immediately, like one treatment, miracle type of thing. But you have those that every time you treat them, they desire 10 cigarettes less a day. And it's like 4 or 5 treatments and they don't crave it anymore. Others, they go down by like 4 a day, and it takes 10 treatments to get rid of the craving. So everybody's individual, and some are going to be miracles, some are going to take, go down just like I described to you, okay? So take it like that, and it works really well. And I'm not going to say it doesn't work, but you have to be very concerned with, are you actually going to make it worse, because they don't really want to quit, okay? 9E, horary points. Okay, horary points point on the meridian that's the same element as the official on which it resides. So it's the fire point of the fire meridian, for example. So here's kind of a dissertation on that. That's the crux of it when you look for those. Horary and energy circulation, 9E. So here is the circulation, and here we're going circulation between points like this, okay? So basically that's where that goes. Here's the chart of general circulation of energy, and in this particular chart you can have interactions between any of these two meridians, but here are the times that they are the most active under this thought, okay? And here you have arm, leg, arm, leg. And it's called the 24-hour clock of acupuncture. So you might treat, for example, the bladder and the kidney, or water meridian. So you would treat the water point of the water meridian. But you may also treat the one directly across from that to get the results for that. So you may have trouble with the bladder. You may have to treat the lung for the bladder also. And that's one of the vagaries of this. And so just recognize that there are many different approaches, because not any one approach works all the time. And I'm interested in you understanding this and getting the best quick results possible just by understanding some vagaries like this. All right, you understand the principle here. Now, that being said, I made up all of this for people who travel like on airplanes. Airline stewards, stewardesses have patients that travel a lot, just like I do. I travel every weekend to teach other professionals. And so they get jet lag. And so they come in to me and they're saying, man, how can I get rid of this constant jet lag? So I give them this chart and I say, okay, just take a toothpick or something like that. And for example, when you hit between 3 a.m. and 5 a.m., you would stimulate that point right there. And I have it circled for them. When you hit the 5 to 7 a.m., you would treat that point. When it's 7 to 9 a.m., you would treat that point, and so on and so forth. And I say it doesn't matter if you're traveling within this country, you're traveling to a foreign country, it doesn't matter. When you cross the time zones, this will help your body to readapt to that new time zone. And I had every single one of them come back and say, oh my gosh, that really, really helped. Thank you so much. So I give them all these sheets of paper. Now you can give those to your patients as well, and just give them those simple instructions. And say that, hey, your body has a circadian rhythm, so when you enter a different time zone, you have to readapt that circadian rhythm to a different time zone. And that's really what all this is about here, okay? 9F. Okay, here's nose, hand, and foot acupuncture. And so here are some nose points, and here's a bunch of organs, and this is another homunculus, so to speak, just like the ear. Now, here you have, for example, the loin, the upper extremities, thigh, knee, toe, foot, etc., etc. Okay? If you remember, the nose points, well, Guyton said that the nose would had the sympathetic nerve endings. Well, after I read that, I had a patient come in, and she said, can you do anything for my hands and feet? They're cold all the time. And I just read that, and I thought, I'm just going to go and take that prod and go over the palms of her hand, palms of her feet. Because, you know, that's what keeps the heat in those areas. And it didn't do anything. And I'm going, well, there's a bad thought there. And then she said, my nose is cold too. Now, she wanted it taken care of because she couldn't snuggle up to her husband at night because her hands and feet were like ice, and he wouldn't let her touch them. Well, after she said, my nose is cold too, I went over the nose, and within seconds, her hands and her feet and her nose warmed up. So from that, every time I have somebody that have cold hands, cold feet, that's the first area that I go to, nose. And I'm right 98% of the time. We're going to discuss another point, I think we already have, back here, that takes care of just the hands, okay? But that's just something that you can do with that. Here's a hand chart. And here's on this particular hand chart, you have polyhydrosis, hyperhidrosis point kind of right up over here, and I'm going to say it should be right here in my experience. And the funny thing is, in this same book, that's where it puts it. Number 28, polyhydrosis, hyperhidrosis. So in the same book, it has differing positions. Now, what I've found in particularly with this is that there's actually about a radius of 3/4 of an inch, so a diameter 1 inch, that can all be affected for polyhydrosis, hyperhidrosis. So I take that small tip probe and I go over that whole area, just like that. Now, stretch it for about 20 seconds. You go back and you get the residual. It's like magic. The hands dry up. Now, I did this on, when I was in Salt Lake City, a doctor drove 15.5 hours one way to get to the seminar, brought his assistant and his family down. The assistant had totally sweaty hands, and she said, I sweat all the time. I did this on her. 5 minutes later, she said, I can't believe it, my hands are dry. I was in Colorado Springs, and Doc said, and she took her hand, she wiped it on the table, you know, which is a Naugahyde table, left just trail of water across it. I did this on her. 10 minutes later, she said, I can't believe this. She wiped her hand. There's no water whatsoever. She said, my hands always sweat. it stopped sweating. This will also stop sweating of the feet, sweating under the arms. I had a doctor go home, and he had one of his assistants that she would put a shirt on. 5 minutes later, her armpit was sweltering. And she had hands that sweat. And she had feet that sweat. He said, you could have fooled me. He said, I didn't think it would work on her. She sweat all the time, everywhere. Her socks and her shoes were wet all the time. Her shirts were wet, etc., etc. I did it on her, one treatment, and it all stopped. Okay? Now, I looked for the other areas when I was finding that diameter in there, because at one point didn't always seem to work, and it didn't really show in the same position all the time on the different charts. Okay? So, that being said, I found all those, so you can use it for all of those. Now, the polyhydrosis, hyperhidrosis point. I had somebody that I treated, and now normally the conception vessel 3 is best for any type of dysuria, and for NOCTURIA, you know, bedwetting, anything like that. And I actually found it first in Trevelyan-Simons as a trigger point. I tried using it as a trigger point. I stuck a needle in there, didn't get anywhere. I tried these on the hand point, on the small finger here, okay. Didn't have a whole lot of luck with those either. But then I thought, well, I wonder if I tap it real hard. So I tap it 3 times real hard over conception vessel 3, and 99% of the time that stops it. And I had a female chiropractor go home. She called me all excited, you know, about 3 weeks after the seminar. She had this patient that's like 23, 24 years old, and her bladder was leaking all the time. And this happens to a lot of women after they have children. And she, at 23, 24 years old, had to wear adult diapers because of the leakage. And she tapped it 3 times. She got an excited call when the woman got home. She said, oh my gosh, I didn't leak all the way home. 3 weeks later, she still wasn't leaking. So the doctor called me and told me excitedly. Well, when I went to Connecticut, patient came in and she brought her son with her. He's 14 years old, and he had wet the bed every day of his life. And so I tapped that conception vessel 3, which had always worked before. Comes back the next day, didn't do anything. So I thought, huh, what else can I do? Then I remembered, and I had the thought, I called an angel whispering in your ear, and are you paying attention? What about the polyhydrosis, hyperhidrosis points? That controls moisture in the body. He was lit up on both sides. Okay, so I added that, and also the same thing that gives moisture to the pelvis, to the vagina, gives moisture to the mouth. So I scraped in the gutter on either side of the tongue, the inner part of the gums, which took care of the woman that we talked about before, her vaginal dryness, and it was really lit up on him also. So I did all those, got the pain out of him. She called me 2 days later. She said, he hasn't wet the bed since you did that. 3 months later, hasn't wet the bed. 3 years later, hasn't wet the bed. Well, as happens, a few weeks after I got home from that seminar, I get a call from a doctor who'd taken several seminars from me before, and he said, I just had a catheter put in, and I don't want to be in this. Do you have anything for it? I thought about this kid. I said, well, I have a seminar in 2 days, El Paso. And so he flew there. So all of those points were active on him. Plus, I adjusted his pubic symphysis. Plus, I did a prostate massage on him. His prostate was lit up. And we did that 2 days in a row. He flew back home. 10 days later, he says, I'm out off the catheter. Thank you so much. Now, he also found that he liked peppercorns. He found that whenever he ingested peppercorns, it would tend to irritate the area again. So we teach about that in Part 4 seminar. So he put 2 and 2 together with that, with the treatments we gave, and he's still not on the catheter. So, you know, sometimes you have to combine things like that in order to get the results, okay? Here's 9F1, and here's another hand point, polyhydrosis right there in the middle of the hand, okay? And here you have NOCTURIA again. And you can use any of these points. Now I want to point out that the butt of the hand is right here. And we went over that previously on the number 9 handout. And this correlates, as you recall, this is the heel point. So correlates with the heel, correlates with the angle of the jaw, ipsilateral, the ipsilateral elbow, the contralateral knee, contralateral heel. So this is one of them in that whole chain, just as a reminder of what we already went over. And we'll just flip that over. You can see that heel point right there, okay? 9G. Here's Royston Low, Great Britain. Now one of the things that point out here is toothache, right here. Now I had found toothache the way that I thought of it. So I would have people come in with toothache, and I would look where the tooth is, and the stomach meridian comes down here, but also loops around up to here. And it goes down to the foot, okay, right in this area. Now, energy flows from one meridian into another. And so I would have people come in, and I tried those cases, I tried trigger points. They never seemed to work with toothaches or gum pains. So I went to the other end of the meridian, and the Akabani point didn't seem to do anything. So I started going up here in the dorsal interosseous areas. So what I found was between these two, basically, first and second dorsal interosseous, usually on the ipsilateral side, although sometimes it's on the contralateral side, you find the most painful spot. And then you have the person do whatever makes the tooth or gum hurt the most, okay? And that could be clenching. It could be drinking something hot like hot coffee, something cold like ice water. Could be crunching down on a piece of ice. It could be a lot of different things. And whatever it is, you have them do that to make it hurt. And then you go and you put a light but firm pressure directly on that point. Usually within seconds, the tooth and gum pain is gone. Okay? Now, that being said, I had a doctor go home. He said he had an infection and he was due to have a root canal done. And he thought, well, why not try it for that? He did that procedure on himself, and he said the infection cleared up. And when you think of it, hey, it's affecting the nerves, therefore it's going to affect the lymphatic drainage, therefore it's going to affect the circulation. Hey, you have a healing process going on here. Well, in his case, it took care of that. I'm not going to say it does it all the time, but I'm just reporting to you that that's what he did. He had this thought and he acted on it, and he didn't have to have a root canal. Now, at a seminar, I had a doctor come in, and he had all of his gums were receding, upper and lower, and all of his gums hurt. That being said, I went and I tried that 1-point reference, just like I told you about. In him, it didn't work. But then I remembered this chart. Now here, they did all of the dorsal interosseous. Now I found this after what I found. And I thought, well, maybe I have to do all of them on this patient. And it turned out I did. I had to quell the most sensitive spot in all of the dorsal interosseous muscles of both feet before this gentleman's cleared up. But he had problems with all of his gums on both sides, upper and lower. So I'm just reporting that to you because you may have someone that happens to. Also, you may want to needle it. I'm just saying that just a firm, light but firm pressure with your thumb generally does it in a matter of seconds, and you don't need to use the needles, in my opinion. Acute low back strain. Now, okay, that's right here, number 20. So, low back pain. And I had found this before, and if you remember, we went over this in that number 9 document. And I found here that somebody else found that the number 20 point was good for low back pain, just like I did. I found this after I found it. So again, here's something that I found that somebody else had found previously, but they didn't find all the other uses around the big toe that I did, nor everything for like the elbow and the wrist and the shoulder and the face and things of that nature. So I found additional things, and you probably will too, and I hope you do. I hope you let me know about it. Now here is another face acupuncture, and this gives a lot of different points that the other ones didn't, that you saw. Now here it shows neck and back right here, and lumbar right here. Now I had and you notice that wasn't on the last chart that I showed you, okay? You're going to see it on another chart, and it's on the next one, but it wasn't on the last one. So, if you don't find everything on one chart, you may find it on another, or you may have to poke and prod around and find something that none of us found before. Well, I had a patient come in, and this patient had ankylosing spondylitis. In other words, all of his vertebrae were fused, his neck down. And try as I might, I couldn't find anything that got rid of it. And then I remembered face acupuncture chart. And it was from Dr. Robert Wilner, which I think we may have in our notes here. We'll have to see. But he had about the same. Now, I did not find those points right where he said it was, and he had them about in the same areas here. What I did find, however, is that when I pressed directly against the nasium on the upper part, it got rid of this guy's cervical pain in a matter of seconds. The middle part against the nasal bone got rid of the thoracic pain in a matter of seconds. The lower part, which was painful, got rid of the lumbar pain. So that angles down. If you notice, these points do not angle down. They don't seem to be related with the nasium bone. However, I found that those points are really good that way. And you notice they combine the neck and back here and separate it from the lumbar. That's not what I found. So that's an interesting point. Now, as we talked about the points that correlate with each other from the jaw and the number 9, guess what? I ran across a few charts that agree with that. The angle of the jaw. Now they put the knee here. I found it was down here. I found the patella was actually here. Above it, the thigh, which here it is on this chart, but the back of the knee would be in the dip here, okay? The outside of the knee would be here. On the inner part of the jaw, right in there, behind the jaw, you would reach around and you would push back. That relates to the inner side of the knee. And the same with the elbow on the ipsilateral side. Now all those are with the leg on the contralateral side. I'm saying, hey, it's the ipsilateral side too. And this would be the lower leg. That's exactly what I found. So it's like you had the thigh here, the knee here, the lower leg going like this. I also found that, hey, this is the heel, and this is the bottom of the foot, and the tongue are the fingers. And here's the elbow, the forearm. There's the wrist, the butt of the hand, and the fingers are the tongue, okay, which they don't have in any of these, but I found those. So back here, for example, if you had an Achilles tendon, because the heel is here, the Achilles tendon would be right here. And this is the side of the thigh, that would be the front of the thigh. And if you remember, I said that the curlers of the jaw would relate to the biceps on the ipsilateral side, the biceps or the hamstrings on the contralateral, they would be here where the clinchers were. So you have kind of a hologram here, and the thing that gets me about this is this relates to the arm and the leg, and guess what? There's the shoulder joint, there's the hip joint. And the saddle joint of the thumb relates to that joint also, okay? So the TMJ joint itself relates to those joints, and it has its kind of hologram that goes right there, and I found those to be very, very consistent. Here we have governing vessel 20, leg and foot. And I had a, okay, right there, governing vessel 20. And you see, you're going to see in another chart where it says foot up in there. And I talked before about the girl that had the scars on the top of her head, that I stuck a needle in there and it corrected her arch in one visit. I left it in there 30 minutes and she came in 2 days later and her arch wasn't falling. Well, that's coming out of these. Now you notice the foot's not really mentioned here. It is up in here, okay? So I don't know why they didn't put it on this particular picture, but that's where it was. And I found that before I ever saw any of these charts with it. Here is, and you're going to see it in, you know, some other pictures here. Here's a line that goes down and across. Here's a sensory area. Here's a motor area. Here's a chorea area here. And tremor, you're going to see in another chart, this is a chorea or a tremor area. So you would take the prod and going down through there. You can take like 5 or 6 inch needles like this, which I've done, and you weave it down through here. You can just take the prod and go down, and it goes from about right there, about 3/4 of an inch behind the eye. You do it on both sides. I've had doctors go home and use that prod on it, call me back and say, I can't believe it. Those scalp points got rid of 85–90% of the tremors just immediately, just using the prod on it. So you can weave the long needles through it, you can use the short needles, you can use the prod, okay? I would tend to err with the thing that's the simplest that caused the least amount of pain and disturbance to the patient. So that's where those points are. 9R, scalp needling therapy. And there is the motor homunculus. And we're going to do a little more of that. Here's the chorea tremor controlled area, motor area, sensory area. And you have other things like speech, vertigo, auditory, etc., etc. Basically, I used to use a 5 to 8 inch needle and weave it down through here. But then I started thinking about just pecking that with the small tip probe, and which I do, and it just gets very, very quick results in most cases. Matter of fact, I've had a slew of doctors that I showed this to at the probe, and they just could not believe it. They called me up and said, I can't believe it. 85–90% of the tremors went away just on the first treatment using the probe on this area. And I put all the rest of it here for your enumeration. And if you remember the girl that had the fallen arch, I found an area here and stuck a needle in it, and the arch held up. That was in a scar. And so all this is here, and I've had people call back and say, hey, I'm using all of this with that probe, and it's just working great. So there it is for you with that. Now out of GUYTON'S, look at that ribbon that goes down here. Okay, it shows you where it is. Primary motor cortex, the somatic area. There's the homunculus. Look at that angle. It's about directly the same. Now, what I don't know, and I haven't really researched, is if the homunculus was here first, and then they started looking at these areas, and you notice these directly correlate with it. They started using needles on those areas, or if they found those anciently, and then we found these recently. I'm not real sure about that. But the fact is it's right over the areas of the brain. Now, when you look at electroencephalograms, they place electrodes all over the head, and basically it emits electrical charges going out directly in the brain over where it is, so they can locate different things based on that. So basically, why not treat that area just above it? And that's Hilton's law of physiology again, okay? So I think either way you look at it, that's a great way to do it. I don't care whether the chicken came first or the egg. I really don't care. 9G1. Here's acupuncture, a comprehensive text. Shanghai College of Traditional Medicine is translation. And here are some other face points. And here you have all these other points here. And it also has the knee and the patella and the lower leg. Those are kind of similar right up in here. Now, I really like this one because you got a lot of organ points right here. Now, that being said, if you remember, I brought up out of Felix Mann's book about the turbinates. I said we would come back to that. And now I used endonasal technique and balloon nasoplasty a lot because I knew that it affected organs from reading Mann's and others' works. But if you recall, the lady that I talked about that I did the scars on her abdomen in Salt Lake City, she also said that she had cold hands and feet. Now, if you remember, use the prod over these areas. And I will tell you that I had an MD fly into Kansas City because she heard that I could help cold hands. And she had RAYNAUD'S syndrome for several years, and it gets cold out and it's like super pain all the time. And it was in the middle of the winter in Kansas City. I did that on her nose with small tip prod. 10 minutes later, she said, "I can't believe it. All my pain and coldness has gone in my hands." Now, she wanted to go to another seminar. She said, "Please tell me in advance about 3 months so that I can sit in for a seminar." And I said, "Okay." And so I called her up a couple of years later, because I usually don't set it that far out. And she said, "Yeah, I want to go to that seminar." So we set her up, and I said, "How's your RAYNAUD'S syndrome?" And she said, "What are you talking about?" I said, "Your RAYNAUD'S syndrome. It's why you went to Kansas City." She said, I don't know what you're talking about." She called me back 2 weeks later. She said, "I don't believe it. You did that one treatment on me, and it got rid of the RAYNAUD'S syndrome. And I haven't felt it since. I'd had it for decades, and I didn't even remember that I had it." That's how beautiful this stuff works, okay? Well, on this lady in Salt Lake City, now I'd started, instead of just going over the nose, I thought, well, maybe I can go under the nose on the bottom. So I would go on the bottom of the nares, straight up the septum here, and maybe a little bit below the nose. And I hadn't really seen these acupuncture points, for the face acupuncture like that. Hadn't looked at it much at all. But this lady, when I did this, she had pelvic pain for years. All the pelvic pain went away when I did it on the underside of the nostril. And I thought, wow, maybe I don't need to do all this pain from the endonasal technique and the nasoplasty, the balloon nasoplasty. So I started doing it with the prod on the underside of the nares, the septum, and across the base here. And I hardly ever have to go inside the nose anymore, and it's very drastically painful when you do that. And I'd rather not, except if I really have to. I found that I could get rid of all that. Now, the beauty of this, look at all those organs that are right there. If you remember, the upper turbinate takes care of the vital organs, the heart, lungs, and kidneys. The middle turbinates are the digestive tract, and the lower nares, the reproductive urinary tract. Well, you can take care of all those by going on that bottom part of the nose and just under it and just inside the nares with the prod also, okay? So you go on maybe 1/4 of an inch inside the nares in certain people, and that'll be lit up. And I've gotten rid of every type of organ and pelvic problem you can imagine just doing that with the prod here very simply. You can use the needle. I'm not saying you don't have to, but you don't really need to do it in most instances. You can just use that small tip prod and get amazing results like benign prostatic hypertrophy, prostatitis, ED. You have a woman that has prolapsed vagina, anteroversion, retroversion of the vagina. You have prolapsed uterus, vagina, bladder. You have bladder conditions. You have ovarian type of conditions. You can take care of most all of those from the nose or from the tongue, like we were talking about, putting pressure on the tongue or the sides of the tongue. So here you have a couple of different alternative methods of taking care of those, either of which may work at any given time. So here you have a few different approaches for that. 9H. Now let's talk about neuropathy and neuropathic myofascial pain. Now, I want you to listen to this real close because we're going to cover a variety of very pertinent topics on this, and it's going to take a while to go over it. Myofascial pain syndromes are a large and diverse group of painful conditions that occur in the musculoskeletal system. They affect muscles and their connective tissue, attachments in any part of the body, and are customarily named according to location of the painful part. For example, lateral epicondylitis, Achilles tendonitis, frozen shoulder, bicipital tendonitis, low back pain, etc. They're puzzling because they seem to arise and persist in the absence of any detectable injury or inflammation. Myofascial pain syndromes are often difficult to treat because medications and commonly available physical therapies give only temporary relief. Innumerable patients therefore wander from provider to provider in a vain search for relief. The term myofascial pain syndrome is used in a vague and indeterminate way to denote any regional musculoskeletal pain syndrome without regard to its source or cause. Careful examination of these syndromes often reveals them to be the effects of neuropathy appearing in the musculoskeletal system. The initial and underlying problem is malfunction of the peripheral nervous system. Pain is just one possible but not inevitable downstream product of neuropathy. Now, neuropathy is a big key word in pain. I think it's overused a lot in the medical literature, but nonetheless, that's how people look at it. The key to successful management of this important and widespread category of chronic pain is to understand neuropathy, how it can cause pain, and recognize it in its many guises. The definition of pain given by the International Association for the Study of Pain is, quote, an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described by the patient in terms of such damage, unquote. Although pain may be linked causally to tissue injury, it isn't necessarily so. Injury does not always generate pain, nor does pain always signal injury. Persistent pain can occur in the presence of ongoing nociception, for example, an unhealed fracture or persistent inflammation. Psychological factors such as somatization disorders, depression, adverse operant learning processes, abnormal functioning in the nervous system. Pain can arise from non-noxious input or from within the body when there is some functional disturbance in the nervous system, such as peripheral neuropathy. Neuropathic pain is generally used to refer to any acute or chronic pain syndrome in which the mechanism that sustains the pain is inferred to involve the aberrant somatosensory processing in the peripheral nervous system or the sensory nervous system. Neuropathic myofascial pain, structural factors exist as well, such as the following that contribute to the pain: muscle shortening, degraded, weakened collagen, trophic changes. C. Chan Gunn proposed the concept of neuropathic pain when it became evident from clinical observations and research that pain is not always a signal of injury, but can be a product of abnormal nerve function. His examination of patients who had back pain but no signs of injury showed that those who were disabled for long periods had tenderness over muscle motor points and affected myotomes. Now remember that in the medical literature we found that motor points, trigger points, and acupuncture points were synonymous, if you remember that, okay? Tender motor points are sensitive indicators of radicular involvement or irritation at the nerve roots. Tender points, now this says the nerve roots. Tender points differentiate a simple mechanical low back strain which heals quickly from one that is slow to improve. Next, the study of patients with tennis elbow showed that tender points at the elbow were secondary to cervical spondylosis. Wow. And radiculopathy, neuropathy originating at the nerve root. So tennis elbow went up to the neck. Wow, imagine that. treating the neck, not the elbow, was able to provide relief. Now, let's go back to the periosteal nerve pecking, the old fractures where you're scraping the callus. Well, remember one of the things that I said is that you could like traumatize the periosteum and basically scrape it to break up the scar tissue or peck it with the acupuncture needle and get rid of the pain there. But on top of that, that would get rid of the neuropathy. I'll give you an example here. Recently, I had a gentleman who just had a heart transplant, and he was having neuropathy and paresthesias in the ulnar part of the nerve. Now, I traced the ulnar part of the nerve, and the normal stuff just didn't work. And so I went up to the cervical area, and there were some painful spinous processes up there. But also there's this thing called the T4 syndrome, and that can involve the vertebrae anywhere from T1 to T7, but usually comes from T4. Well, I found that that was what was going on with him, so I scraped the T4, and it dissipated it somewhat, but not all the way. So I took a smaller tip probe and I followed it out just lateral toward the side of the pain and paresthesias, neuropathy and the paresthesias, and we went out maybe 1.5 inches lateral, and we extinguished all those points with this small tip probe. And as we did it, all of the neuropathies and paresthesias left in the ulnar nerve. So basically, the T4 syndrome can have an effect on the skull cap from the wrist through the fingers, from the elbow through the fingers, or from the shoulder through the fingers. That's where I thought of when the regular stuff didn't work, and it turned out to work. And he texted me the next day. He says, "Oh my gosh, I feel amazingly better. That got rid of all of the neuropathy and the paresthesias. Thank you so much." So sometimes you got to kind of combine these concepts in your head. If one doesn't work, you use another one. And that's how acupuncture or chiropractic or anything does. One thing doesn't work, you go try something else. So I'm just telling you things out of my own experience that just made sense to me, and I followed it up and it worked. So here we had treating the neck, not the elbow, was able to provide the relief on the tennis elbow. Study of pain in the shoulder likewise implicated neuropathy at the cervical spine. So here we have shoulder and neuropathy at the cervical area, okay? So, I want you to go off on this. I'm giving you a lot of different things to consider, and things that I've found that work very quickly as opposed to jumping from one thing to another and having to guess and guess and guess. Well, these things tend to work really quickly, and you can reference them pretty quickly just by the symptomatic location, okay? A pattern emerged. Patients who have pain but no signs of injury generally have sensory, motor, and autonomic manifestations of peripheral neuropathy. Now, I would disagree with no signs of injury, because I think that these people at some point in time maybe fell, maybe got in a minor fender bender, they had their neck whipped, fell down, got hit, something at some time in the past, and over a period of time, scar tissue, there was small inflammation and scar tissue formed. It got a little worse, a little worse, a little worse, and then it started manifesting as symptoms. So the things that caused it may have happened decades ago, but it just recently became symptomatic. So no signs of injury. I think if you track it back far enough, you will find signs of injury somehow, okay? Peripheral neuropathy may be defined as a disease that causes disordered function in the peripheral nerve. Now, as you look at this, just kind of look at where the sympathetic nerves come from, okay? The upper extremities sympathetic nerves that control that area tend to be, let's say, from the 1st to the 5th thoracic. And to the lower extremities, from about the 10th thoracic to the 3rd lumbar in those ganglia. However, if you really comb the literature, it says that it can go about 5 levels off of that, roughly. Although sometimes associated with structural changes in the nerve, a neuropathic nerve can deceptively appear normal. It conducts nerve impulses, synthesizes and releases transmitted substances, and evokes action potentials and muscle contraction. Following neuropathy and denervation, many diverse pain syndromes of apparently unrelated causation may be attributed to supersensitive receptors or nociceptors and hyperreactive control systems at internuntial pools. Now, this is all within the central nervous system, the spinal cord, etc. And I find it interesting that in particular, the conception and governing vessels are called a lake, which contributes to, but doesn't interact with necessarily, all the meridians, and they dump excessive energy into it. That would be just like internuntial pools. The following attributes are generally associated with neuropathic pain. Pain when no ongoing tissue damaging process exists, delay in onset after precipitating injury, generally taking approximately 5 days for supersensitivity to develop. Dysesthesia, unpleasant burning or searing sensations or deep aching pain, is more common than dysesthetic pain and musculoskeletal pain syndromes. Pain felt in a region of sensory deficit. I think what's going on here is that the body is trying to cover up pain with numbness. I had a gentleman come in from Phoenix just last week, and he had a sensory deficit in both hands, with basically, with the exception of the little finger, had from the knuckle and the palm here all the way through the fingers and the thumb, the distal interphalangeal joint, all on the pad side. I had to go basically in and progressively use smaller and smaller prods and finally scrape the periosteum of those digits, and we got rid of 90-95% of the pain, just in a few days. But I think because of the pain that we found underneath and all the scar tissue basically that was precipitating it, that the overlying numbness was some type of effort by the central nervous system to cover that pain up. And he had had that for several years, basically. Neuralgic pain, paroxysmal brief shooting pain or stabbing pain, severe pain in response to a noxious stimulus or hyperalgesia, severe pain in response to a stimulus that is not normally noxious or allodynia, pronounced summation and after reaction with repetitive stimuli. Neuropathic pain is perceived as beginning with peripheral sensitization. In peripheral sensitization, increased transduction sensitivity of nociceptors is associated with alteration of ionic conductances in the peripheral terminal. Sensitization can occur following tissue inflammation or damage to a peripheral nerve. Inflammatory cells produce growth factors and cytokines that contribute to the increased sensitivity of nociceptors, but damage to the peripheral nerve is mostly commonly caused by spondylosis at the root level or neuropathic pain, when all fibers of the peripheral nerve can be damaged and can lead to any of or all of the following: Motor. Muscle shortening is the most significant feature of radiculopathy, pain caused by the mechanical effects of muscle shortening. Now this is mostly found by the vertebra centrally there, and those particular muscles are not controlled by the conscious mind. Autonomic. Increased vasoconstriction, hyperhidrosis, trophodema, causalgic pain, also called reflex sympathetic dystrophy or complex regional pain syndrome. Trophic. Dermatomal hair loss, collagen degradation, frailty, leading to enthesopathic tendons. I took care of a gentleman in chiropractic college. It was right after I learned about spondylotherapy, which was developed by Albert Abrams. And basically you have a tone of about 1 beat per minute. And he said that whenever you want to reestablish circulation, you would either tap at a rate of 1 per second in the sympathetic area, controlling it, which in this case was about T5 down to L3. He always included around C7 or T1 where the stellate ganglia is, which has a control over all the circulation in the body. And when you're tapping on that area and the person has no shoes or socks on, the feet are extended out, they can feel electricity going through their feet and toes. And so we did this, and he recommended about a minute at each level until the desired results were there repetitively. So we did it once a day for about 10 days, and that was roughly about 10 to 12 minutes. And at the end of that, now he had no hair from his knees down through his toes. It had all fallen off, and he said he couldn't walk for more than 5 steps without his calves cramping so hard he couldn't walk, so he had to use support hose. After that, he never needed support hose anymore, and all of his hair grew back. So basically we were reprogramming the nerves with this spondylotherapy. Minor damage to the nerve root isn't clinically obvious. Radiculopathy is universal, but usually unsuspected in pre-spondylosis when painless muscle shortening precedes peripheral sensitization. I think the minor damage to the nerve root isn't clinically obvious because you have a small injury that over time scar tissue builds up and constricts the tissue and strangles the nerves, the capillaries, the lymphatic vessels, the nerve fibers, etc., etc. So you got to break up those small amounts of adhesions. A lot of that can be in the skin or on the surface of the bone. Damaged primary afferent fibers demonstrate spontaneous activity, exaggerated response to stimulus, sensitivity to catecholamines. These are explained by Cannon and Rosenbluth's law of denervation, but is seldom cited to explain neuropathic pain. It points out that normal physiology and integrity of all innervated structures are dependent on the arrival of nerve impulses via the intact nerve to provide a regulatory or trophic effect. When this flow, probably a combination of axoplasmic flow and electrical input, is blocked, innervation structures are deprived of the trophic factor, which is vital for the control and maintenance of cellular function. So basically you have muscle tension and spondylosis compressing the nerve and impeding the axoplasmic flow, so the nerve doesn't work right. Atrophic structures become highly irritable and develop abnormal sensitivity or supersensitivity according to Cannon and Rosenbluth's law of denervation, which is when a unit is destroyed in a series of efferent neurons and increased irritability to chemical agents develops in the isolated structure or structures, the effect being maximal in the part directly denervated. All denervated structures develop supersensitivity, including skeletal and smooth muscle, spinal neurons, sympathetic ganglia, adrenal glands, sweat glands, brain cells. Cannon and Rosenbluth's work was based on total denervation or decentralization for supersensitivity to develop. Accordingly, they named the phenomena denervation supersensitivity. So basically, he was talking about cutting a nerve. But now it's known that physical interruption and total denervation aren't necessary. Any circumstance that impedes the flow of motor impulses for a period of time can rob the effector organ of its excitatory input and cause disuse, supersensitivity in that organ and in associated spinal reflexes. The importance of disuse supersensitivity can't be overemphasized in that when a nerve malfunctions, the structures it supplies become supersensitive and behave abnormally. These structures overreact to inputs involving chemical stretch and pressure. Supersensitive muscles can generate spontaneous electrical impulses that trigger false pain signals or provoke involuntary muscle activity. Supersensitive nerve fibers become receptive to chemical transmitters at every point along their length instead of only at their terminals. So basically the whole nerve becomes involved. And you can stimulate any nerve anywhere along its length and have a nerve impulse. It doesn't have to be at a certain point. Sprouting may occur, and denervated nerves are prone to accept contacts from other types of nerves, including autonomic and sensory nerve fibers. So they're trying to reestablish a connection by sprouting, forming a new nerve basically. Short circuits are possible between sensory and autonomic or vasomotor nerves and may contribute to complex regional pain syndrome. Many diverse pain syndromes of apparently unknown causation may be attributed to the development of hypersensitive receptor organs. Many diverse pain syndromes of apparently unknown causation may be attributed to the development of hypersensitive receptor organs and supersensitivity in pain sensory pathways. Instead of nociception, there can be severe pain in response to a noxious stimulus or hyperalgesia, or severe pain in response to a stimulus that is not normally noxious, or allodynia. So those are two very important types of nerve responses. Radiculopathy is neuropathy at the nerve root due to spondylosis. So basically, hey, it's happening at the spinal level. Spondylosis is the structural disintegration and morphologic alterations that occur in the intervertebral disc with pathoanatomic changes in surrounding structures. The spinal nerve root, because of its vulnerable position, is notably prone to injury from pressure, stretch, angulation, and friction. Spondylosis increases with age. Therefore, spondylotic pain is more common in middle-aged individuals who have accumulated an injury pool, an accumulation of repeated major and minor injuries to a segment leading to unresolved clinical residuals that may or may not produce pain. So here we have a lot of small injuries adding up to a big injury over a period of time. Major or minor damage to joint connective tissue can provoke, evoke, or invoke fibrosis. Scar tissue multiplies in a vicious cycle and contracts with age. Progressive joint fibrosis causes joint degeneration or spondylosis and neuropathy, sometimes progressing into bony ankylosis. This limits joint mobility, preventing activation of chondrocytes, compresses the joint, preventing imbibition. So you got two reasons why the joint degenerates. The above causes progressive joint connective degeneration or degradation, spondylosis, with accompanying neuropathy through lack of joint cartilage production and hydration of the joint. Impulse cavitation adjusting disrupts the scar tissue, reinstates joint mobility, allows the joint to regenerate, reverses the spondylosis and resultant neuropathy. So look at what happens with chiropractic here. They're basically saying chiropractic is necessary to get somebody through neuropathy. Spondylosis ordinarily follows a gradual relapsing and remitting course that is silent unless and until symptoms are precipitated by an incident often so minor that it passes unnoticed by the patient. And this is repeated several times in the medical literature. All gradations of spondylosis can exist, but early or incipient spondylotic changes, even when unsuspected, can nevertheless irritate and upset function in the segmental nerve. Acute injury to a healthy nerve has no prolonged discharge of pain signals, whereas the same injury to a neuropathic nerve can cause a sustained discharge. For pain to become persistent, affected fibers must be previously irritated or defective, which is why some people develop severe pain after an apparently minor injury, and why that pain can continue beyond a reasonable period. Ruth Jackson, in her book Cervical Syndrome, basically talks about this in 3 or 4 instances. You have somebody with a quiescent degeneration that's asymptomatic, and it just takes a small jolt and they become very much symptomatic, and it takes a lot to get them out of those symptoms. That's in Ruth Jackson, The Cervical Syndrome. Manifestations of neuropathic dysfunction are motor, sensory, and autonomic. Brief transient motor manifestations are the first to appear, and radiculopathy can occur without pain. Muscle shortening is an early and regular feature of radiculopathy because of large diameter nerve fibers at the nerve root. Axons of motoneurons and myelinated primary afferents, muscle proprioceptors, are the first to suffer physically. Painless, reversible tight muscle knots can be felt in most individuals, and it's talked about a lot in Travell and Simon's trigger point books. That's exactly the terminology that they use, muscle contraction knots. Pain isn't therefore a feature of radiculopathy unless nociceptive pathways are involved. Many neuropathies are pain-free, such as pseudomotor hyperactivity and hyperhidrosis, muscle weakness, and ventral root disease. Degradation of collagen. Neuropathy contributes to degenerative conditions including spondylosis. Neuropathy degrades the quality of collagen, causing it to have fewer crosslinks, making it more frail than normal collagen. Now, some of the major things that help form collagen are vitamin C, vitamin A, but the crosslinks are from copper, and we talk about all this in part 4. You can also look for a discussion on my YouTube channel, Ttaps channel, and we go over this in some depth. The amount of collagen in soft and skeletal tissues is also reduced, and because collagen lends strength to ligament, tendon, cartilage, and bone, neuropathy can expedite degeneration and weight-bearing activity stress parts of the body, including the spine and joints, becoming a source of pain. Enthesopathic thickening in tendons are possibly compensations for this weakness. So they get thick because there's a lot of stress on it all the time, and they are trying to stabilize the area basically. Central mechanisms in neuropathic pain. Interactions between peripheral and central mechanisms occur to produce post-injury hypersensitive and neuropathic pain. The spinal cord isn't just a passive conveyor of peripheral sensation to the brain because it can modify or amplify incoming signals. So here we're going right back to the spinal cord. Central sensitization, a state of hyperexcitability of the dorsal horn neuron, can occur after damage to a peripheral nerve or spondylosis, or low-frequency repetitive C-fiber nociceptor input from peripheral tissue inflammation as in arthritis. Central sensitization is from increased spontaneous activity of dorsal horn neurons, increased response to afferent input, expansion of receptive field size, reduction in threshold, prolonged after discharges. Central sensitization leads to a cascade of molecular events, such as activation of the N-methyl deaspartate or NMDA channel, increase in extracellular calcium, wind-up or wide dynamic range, WDR, neuron sensitization, and other phenomena. Altered sensitivity in the dorsal horn. Central sensitization may be maintained by ongoing primary afferent input, altered central neural circuitry, or both. Wolf identified 4 stimulus processing states. Normal. Touch is perceived as innocuous and high-intensity stimulation is pain. Suppressed. High-intensity stimulation isn't painful because of inhibition from segmental inhibition or descending inhibition from higher centers. Sensitized. Low-intensity stimulation is perceived as painful mechanical allodynia, and high-intensity stimulation, which is normally painful and leads to hyperalgesia. Reorganized. Possible structural changes and reorganization of dorsal horn circuitry in which inappropriate synapses may form by sprouting, causing low threshold afferent input to be misinterpreted as pain. AB afferents acquire the capacity after inflammation to produce central excitability, which they normally can't do. So the body's trying to compensate for all of this. Expansion of receptive field size. Pain. Radiating several segments above and below the level of nociceptive stimulation may be explained by dispersion of the primary afferent input through propriospinal connections in adjacent layers 5 and 6 of the dorsal horn. This area also contains WDR neurons, called this because they can encode a range of stimuli from light touch to intense pain. The WDR receptive field is immense compared with that of the primary afferent neuron, and any increase in nociceptive stimulation can lead to the recruitment of many more WDR neurons. Prolonged after discharges. Perceived pain can outlast the stimulus. In neuropathy, discharge from pain fibers generates prolonged activity of WDR neurons because normal inhibitory effects of activity is lost. Wind-up phenomena is frequency dependent. Low frequency input gives a constant response from dorsal horn neurons. Frequencies greater than a half hertz can give rise to hyperexcitability, lasting many minutes after the stimulus. C fibers release chemical substances onto dorsal horn neurons. There are 2 types of receptors at the dorsal horn: neurokinin and NMDA for amino acids. Binding of amino acids to the NMDA receptor depends on its prior activation by the binding of substance P to the neurokinin receptor, so release of substance P may lead to recruitment of a second receptor type, or NMDA, an exaggerated response to further stimulation. The sensitized cell undergoes other biochemical changes as indicated by expression of the gene CFOS. Products of CFOS expression are involved in regulation of neurotransmitter and nerve growth factor synthesis. Challenges in diagnosis and treatment. Diagnosing pain and dysfunction caused by radiculopathy depends almost entirely on the examiner's clinical experience and acumen. Wow, so much for science, huh? That is why healthcare is both science and an art. You gain experience and you figure things out, basically. History gives little assistance. Pain often arises spontaneously with no history of trauma, or else the degree of reported pain far exceeds that consistent with the injury. Lab and imaging are generally not helpful. Thermography reveals decreased skin temperature and affected dermatomes, an indication of neuropathy, but doesn't necessarily signify pain. Radiculopathies are difficult to document with routine nerve conduction studies, which measure only the few fastest conducting and the largest fibers, take no account of the majority of smaller fibers. In focal neuropathy, nerve conduction velocities remain within the wide stimulus of normal values, but F-wave latency may be prolonged. Electromyography is not specific. Physical signs of neuropathy are distinctive and different from well-known ones of outright denervation, such as loss of sensation and reflexes. They are important to look for because they indicate early neural dysfunction for which no satisfactory lab or imaging tests exist. Careful inspection for signs of motor, sensory, and pseudonomic, that is vasomotor, pseudomotor, and pilomotor, dysfunction in the skin and affected muscles is necessary. Vasoconstriction differentiates neuropathic pain from inflammatory pain. Neuropathic pain affected parts are perceptibly colder. There may be increased pseudomotor activity, and the pilomotor reflex is often hyperactive and visible in affected dermatomes as goosebumps. Now, Trebell and Simons, they say when you hit a trigger point to treat it, goosebumps are frequent. There can be interaction between pain and autonomic phenomena. A stimulus such as chilling stimulates the pilomotor response and can precipitate pain. Conversely, pressure on a tender motor point can provoke pilomotor and pseudomotor reflexes. Increased permeability in blood vessels can lead to local subcutaneous tissue edema. Neurogenic edema or trophodema, seen as paw to orange skin, confirmed by the matchstick test. You may not have heard of the matchstick test. Pitting edema, you press with a finger and it doesn't come back, but that doesn't necessarily happen here. Trophodema is non-pitting to digital pressure, but when a blunt instrument such as the end of a matchstick is used, the indentation produced is clear-cut and persists for many minutes, so you have to use something smaller in this case. A quick and simple test that can demonstrate neuropathy earlier than electromyography. Trophic changes such as dermatomal hair loss may also accompany neuropathy. Neuropathic changes are primarily in muscle. Even when symptoms appear to be in joints or tendons, signs in muscles are the most consistent and relevant. Increased muscle tone, tenderness over motor joints that should be motor points, taut and tender palpable contracture bands, restricted joint range. Each constituent muscle must be palpated and its condition noted. Palpation requires detailed knowledge of anatomy, and clinical skill comes only with practice. Because many paraspinal muscles are compound, such as the longissimus, and extend throughout most of the lengths of the vertebral column, the entire spine must be examined, even when symptoms are localized to one region. Muscle shortening from contracture. Muscle contracture is a fundamental feature of musculoskeletal pain and of all structures that can develop supersensitivity. The most widespread is striated muscle. Contracture can physically give rise to pain by its relentless pull on sensitive structures. Classic contracture refers to the evoked shortening of a muscle fiber in the absence of action potentials. According to Cannon and Rosenbluth, skeletal muscle can become supersensitive in several ways. Increased susceptibility, lessen stimuli that don't have to exceed a threshold can produce responses of normal amplitude. Hyperexcitability. The threshold of the stimulating agent is lower than normal. Superreactivity. The capacity of the muscle to response is augmented. Super duration of response. The amplitude of response is unchanged, but its time course is prolonged, so it's there for a long time. Supersensitive skeletal muscle fibers overreact to a wide variety of chemical and physical inputs, including stretch and pressure, and have a lowered threshold to acetylcholine, itself increased from reduced levels of acetylcholinesterase. Acetylcholine slowly depolarizes supersensitive muscle membrane, inducing electromechanical coupling in which tension develops slowly without generating action potentials. And basically, I would add over time, because inflammation and immobilization cause scar tissue or fibrosis, this is going to cause fibrosis. Okay? In normal muscle, acetylcholine acts only at receptors that are situated in the narrow zone of innervation. In neuropathy, it acts at newly formed extrajunctional receptor receptors or hotspots that appear throughout the muscle. So basically the whole muscle is sensitized. Treatment. Pharmacologic management of neuropathic pain is difficult, and there is no long-term data to support the effectiveness of any drug in treating this condition. Physical medicine. Neuropathic pain is a supersensitive phenomenon, and its treatment requires desensitization. Supersensitivity and other features of denervated muscle can be reversed by electrical stimulation. Now, I might add that Albert Abrams also said, okay, use electric stimulation about 1 per second, or you can press on the area. This is Dr. Bonebreak. Physical medicine also achieves its effect by stimulation. Local therapy excites receptors in skin and muscle. For example, massage activates tactile and pressure receptors. Exercise, manipulation, and dry needling stimulate muscle spindles and Golgi organs. Heat and cold act on thermoreceptors, so it can be any number of different types of stimulus. These are sensitized by specific receptors transduced into nerve impulses and relayed to the dorsal horn. All forms of physical medicine, including dry needling, are effective only when the nerve to the painful part is still intact. Removing the cause of neuropathy is key to treatment. Spondylosis is by far the most common cause of radiculopathy. Local treatment such as manipulation, they're saying chiropractic really helps this. Massage and dry needling should be given to all tender and shortened muscles in affected myotomes, including paraspinal muscles. Outcomes of treatment depend on appropriateness of type of therapy used and the skill of the practitioner. Here again, we are looking not only at the science, but you have to have the art, the skill of the practitioner over time. Fine, flexible acupuncture needles used in intramuscular stimulation find and release contractures, and deep contracture can only be released by probing with the needle, which transmits feedback information on the nature and consistency of the tissues it is penetrating. When penetrating normal muscle, it meets with little resistance. When penetrating a contracture, there is a firm resistance, and the needle is firmly grasped by the muscle, causing the patient to feel a peculiar cramp-like or grabbing sensation from the shortened muscle, which gradually eases off during treatment as muscle shortening is released in minutes. Referred to in acupuncture literature as the DEDUCE or TECHI response, which response is an important finding, a sign of muscle contracture confirming the status of neuropathy. Now, I might add, when you do this properly, you're going to trace this ropey muscle and you're going to find a nodule in one. There's going to be a specific knot. That is where you insert the needle. For the DEDUCE response, the dry needling, however you want to call it. Okay. The muscle is shortened and neuropathic. According to Fields, the strange quality of neuropathic pain, a peculiar cramp-like quality, probably results from disruption of the sensory apparatus so that a normal pattern of neural activity is no longer transmitted to the perceptual centers. Allowing the neuropathic pain probably activates nociceptive neurons because the message that gets through to the perceptual centers is clearly unpleasant, but patients distinguish them from normal pain sensations, so they can tell the difference. Chronic myofascial pain sensations are not normal in that they are associated with receptors that sense muscle shortening, or proprioceptors. Progressive tactile hypersensitivity. Ma and Wolf describe progressive tactile hypersensitivity, finding that repeated light touch to an inflamed area produces cumulative allodynia persisting for hours, demonstrating the capacity to produce windup of spinal cord neurons. So here we have And it's kind of compacting all this and saying, okay, this is how it acts in succession. This is distinct from central sensitization induced by stimulation induced in non-inflamed tissue lasting only for minutes. Cutaneous nerves contribute by Hilton's law of physiology because the same nerves control both the overlying skin and the underlying tissue, muscles, tendons, ligaments, whatever. In chronic pain, fibrosis eventually becomes a major feature on the contracture, and dry needle treatment is much less dramatic. The extent of fibrosis doesn't correlate with chronologic age, and scarring can occur after injury or surgery. The treatment of extensive fibrotic contractures necessitates more frequent and extensive needling to relieve pain in all tender bands. It's uncommon to encounter a muscle that's totally fibrotic and cannot be released by vigorous needling. So basically you got to needle it several times. Basically we use a probe and we scrape it and then we stretch it, and that releases it, I think, much quicker than a needle does. And we show this over and over in seminars. For long-lasting pain relief and restoration of function, it's essential to release shortened paraspinal muscles that may be compressing a disc and disperse fibrotic tissue that is entrapping a nerve root. So basically you're going to take that small tip probe and you're going to press and scrape. You have to press firmly and scrape, or you're not going to disrupt that scar tissue. Summary: many neuropathic conditions are pain-free because pain is a manifestation of neuropathy. Therapy should aim at the cause of the neuropathic condition. Spondylosis is by far the most common cause of radiculopathy. Myofascial pain syndromes are almost invariably segmental, found in dermatomes, myotomes, and sclerotomes. An examination must always include the spine. Look for vasoconstriction and trophodema as signs of neuropathy, as distinguishing it from denervation. Neuropathic pain has a proprioceptive component, cannot exist without muscle shortening, tender shortened muscles, and myotomes. Neuropathic pain is often the unsuspected cause of many other conditions, such as tension headache, frozen shoulder, tennis elbow, and low back pain. Muscle shortening upsets joint alignment and increases pressure on articular surfaces, degrading the quality of collagen and contributing to the degeneration in weight-bearing and activity-stress parts of the body. Radiculopathy is perpetuated when shortened paraspinal muscles draw adjacent vertebrae together to compress the disc and irritate the nerve root, and the vicious cycle must be treated at the spine. Properly treated, the signs disappear, often within minutes. Exploratory laparotomy or laparoscopy may stretch, avulse, or otherwise damage either the ilioinguinal or iliohypogastric nerves, or both nerves. The neuropathy may result and develop after variable intervals. The pain may begin days, weeks, or even months after the injury, and it's common that there is a gradual escalation of pain over time. This type of neuropathic pain is usually burning or stabbing and may incapacitate the patient, may involve cutaneous nerve entrapment or injury, and the diagnosis of chronic lower abdominal pain following surgical exploration. So here you're going to have to go directly on the scar, as we previously discussed. Such injury can also follow trauma, auto accidents, or exercise. Other descriptives including stabbing, crampy, burning, or aching pain, which may not radiate to upper thigh, labia, or scrotum. Examination includes the direct palpation of the local area with the blunt end of a pencil or pen with pressure distributed directly vertical downward. Immediate relief is the usual reaction to dry needling. Ilioinguinal and iliohypogastric disturbances often have surgical or other types of trauma in the area of the lower abdominal wall. The genesis of the pain isn't known, but suspected retraction placed on nerves around the incision line that may result in overstretched and avulsion type neural injuries. So here you have the incision line. Again, take that probe and go on the scar tissue itself. Sometimes you got to use a needle on any residual points, but generally not that often. Genitofemoral nerve disorders are neuropathies with reports of low abdominal pain or back pain that has migrated to the front of the body, descending into the scrotal or labial area. Tender point dry needling usually provides pain relief. All these types of neuropathy: chronic pain, pudendal, ilioinguinal, hypogastric, genitofemoral, hymenal, sympathetic pelvic, sciatic and obturator, intercostal, lower extremity, upper limb neck pain, parasympathetic. Neuropathic pain is a complex biological phenomenon with many components. Abnormal afferent barrages that propagate into the central nervous system directly will elicit paresthesias, dysesthesias, and pain, burning pain, and intermittent spontaneous bursts. Painful scars can be surrounded by touch-evoked allodynia, radiating to various areas due to central sensitization from the area of the most severe neuropathic pain. Nerve block or dry needling of the scar from which the noxious input originated triggered a spinal central sensitization, eliminates the allodynia, scar pain, dysesthesias, and paresthesias. As we talked about, using that small tip probe. So you don't necessarily need the needles. Sometimes I just do it to save time, basically. 9H1. This is where a lot of this information came out of on the dry needling, etc. So this is Bonica's Management of Pain. I named a couple other sources as well.